Perhaps Pete and Patricia are actually going to have the answers for us because they were working on harmonization of competencies, and I'm sure they will. Are we ready with their slides? Yeah, there we go.
So we had a very interprofessional group, and we learned a lot about, from, and with each other, and we generated this in a collaborative way. And I thought the only way we should present it is in a collaborative way. So now the pharmacist and the nurse, Patricia, Hinton, Walker, and I are going to do this, and we're going to tag team this, and hopefully it'll work. Is there a clicker there?
Thank you. I'll let you be in charge.
Great. So, and because we have 6 minutes, we're going to go extremely fast. So we started out asking people what they wanted to get out of it. They wanted to, even though we were talking general competency-based education, we quickly got to IPE, but better understanding competency-based standards, and then interprofessional collaborative practice that, unless we're getting there, that we're not achieving what we ultimately want. And then we have extra slides. So these are the 3 questions that we went after first together. What is competency-based standards? What's their purpose and who develops them? And you're going to hear a fair amount of overlap with what we just heard. Where do competency-based professional standards occur in the lifespan of professionals, and how are they evaluated? And what do competency-based standards relate to the types of standards or to entrusted professional activities as a fairly new buzzword? So your turn.
Mm-hmm. So when we talked about competency-based professional standards, for what purpose and who develops them, we actually wanted to make sure it incorporated knowledge, skills, values, and ethics. We had a little bit of a conversation that in a lot of this, there's not evidence to base it on, but evidence-driven, because we may not have this research yet, so we wanted to be sensitive to that language. The purpose, obviously, ethics, leadership, and having it toward outcome-based competencies, and then obviously we thought about the multi-stakeholders that have already been mentioned, and that in some cases it would be process-driven, but ultimately getting to the competency, so we had to address both.
Then we asked, where do competency-based standards occur in the lifespan? And I think a lot of our thinking around this has been at the degree level. But in fact, there are residency standards, there are continuing education, standards, there's maintenance of certification standards, et cetera. So it's not just, preparation of students. And that was a concept we wanted to get out there. There's health insurance standards about who can and who not get, allowed to do certain things. And some of that is looking at even how the technology issues here of simulation, gaming, standardized patients, OSCEs, and TOSCEs, team-based OSCEs. So all this is going into where some of this is occurring along the lifespan and how it's occurring and what's evolving in the technology space.
Looking at how it relates to other standards, the major thing that we really talked about is it can be global in some cases, multifactorial, based on a needs assessment in a particular community or space. There need to be both generic ones in general and specific, related not just to standards of practice, but also in hit by the regulatory issues. And that we have to have demonstrable skills when you talk about competency-based.
And this got to entrustable professional activities, so that even though you say the doctor will be able to do patient care, that translates into they got to be able to do a history and physical, they ought to be able to enter their information in the chart and prescribe appropriately, et cetera, et cetera. And this is so that the medical schools are preparing people to go into the residencies with a list of 13 guaranteed 100% skills that are going as this evolves into the future, whereas competencies, as we heard at the individual level, not everybody's going to pass the licensing exam first time, et cetera. So then we asked, where do the accreditors fit in? What types of accreditation there is? How does it vary, et cetera? And we'll do these one at a time. So, Patricia?
So when we looked at where the accreditors fit in, we think in terms of setting the standards and the evaluation, from a quality assurance perspective as well as quality improvement versus quality advancement. So in other words, just quality improvement, fixing things weren't enough about what do we need to do to advance it. Monitoring, ongoing monitoring, and looking both at the program level as well as the institutional level.
And, here we have specialized professionals, institutional, regional, national, international, residencies. So there's all kinds of accreditors flying around here.
And then we talked a little bit about how this varies across professions and countries. First of all, that we have varying health systems in different countries as well as in practice areas, and different professional competencies that are expected in different countries. And then the state-by-state variation, we talked about quite a bit about that in both practice and regulation, which impacts competencies in ways we hadn't really talked about very much. And then we just used the example of the compact licensure in nursing could be a model for other professions that have wondered how it is we were able to credential across settings and across states rather than having all the barriers, particularly in the context of telehealth and the way that the technology is beginning to drive practice.
So here you cannot read this slide, but it's very informative. What are opportunities, noteworthy practices, and barriers for harmonization? So first we talked about harmonization versus standardization, and the difference is the standardization being very specific, it has to be done the same way, versus, we really want these competencies and you can go about it in different ways as long as we get there. And there's opportunities here to add a lot of the things that Malcolm was talking about and address these things, ethics, professionalism, moral agency at the level of the individual, the organization, and society. So we listed a whole bunch of this stuff, leadership, and again, I won't read you the slide, but near the end, we started to talk about where are some noteworthy practices out there, and we could all name centers that we are aware of that are really doing this well, and that even our licensing bodies are now talking to each other. Medicine, nursing, and pharmacy have been talking for a while. And we have the IPEC group as a model, the HPAC group, the accreditors in trying to get together, and the IOM, quite frankly. This session here is a great noteworthy practice for trying to move this field forward.
Then we just identified some of the barriers, and some of these would be obvious to many of you. We felt like in the past and in this shifting that the payment structures have really been one of the major barriers to make the change. Medical hierarchy in some cases. Again, the scope of practice in different states is different, as well as criteria for licensure. And then when you look at the benefits within an institution, who gets credit for it if we have it interprofessional, and who gets credit for that in terms of workload as well as money and tuition, and also the barriers that are sometimes there relating to cross-professional ability to do that IPE assessment. So sometimes that's built in, and we saw those as barriers. Opportunities, obviously, how to measure it, the fact that we're focused on quality and safety, and that can drive the team perspective, as well as the opportunities, going back to IPEC, and the opportunities for continuing education, doing that in an interprofessional way rather than it being siloed as much as it has been in the past.
So here we were looking at the ideal state, and we pretty much defined it as if we could solve some of these barriers and move forward on some of these opportunities here, that we would get to the ideal state. And again, if we have any questions, we'd be happy to try and address them.
Okay, so the collaborative team model uses more than their 6 minutes allotted. We will give them the opportunity
well
to
done.
one to two
Good
questions.
patient care takes
Only
time.
thanks to their colleagues at the table. Does anybody have any questions or points of clarification? It was pretty comprehensive.